Good afternoon, all. I hope you can see my screen.
Yes, sir. Yes, sir.
Yes, good. So, going to discuss about ocular pharmacology and a little bit on clinical pharmacy, which is not usually discussed anywhere else when we are teaching the postgraduate students. It's very important from all point of view. What is more important is that the student always have a curiosity that in case if a drug is approved for some other condition, for example, even in the case of memantine, there was such a huge interest on this drug that once if it was approved for Alzheimer's, for neurodegeneration, immediately the young postgraduate is so much motivated to test it for glaucoma, where we are looking forward for some sort of prevention. But you understand that this is a common knowledge when we try to do even for the postgraduate thesis work, we try to select such type of drugs. But now the last 10 years that and the advancements in ocular pharmacology is so much that a modern understanding about how the way our eye behaves and means what type of problems which are happening in the eye as far as drug transport is concerned is very important for us to teach the postgraduates. Actually, this helps them that in their private practice or when they go out or in the clinical practice, which type of drugs they will be able to choose, which are not. And sometimes we say that, okay, use this, but we won't be able to understand that why we supposed to do it. In this kind of problems do arise sometimes in case of endophthalmitis, which type of drug I supposed to use. So this this is a very typical case study which came up, the glaucoma in which memantine completely failed when the drug is able to cross the blood-brain barrier. Why not eye? So well, this completely we understand now that the eye is behaving much more different. It's like just behaving like an island in the body. Now we have to make them understand about two things about the blood retinal barriers and the blood aqueous barriers and blood corneal and sclera. Even they are behaving as a barrier. The drug cannot just, when you put an eye drop, it cannot just go inside. I mean, hardly about 1 to 2% of the drug which is instilled, which gets inside. So the amount which is reaching inside is very low. Sometimes we use 1%, 2% pilocarpine, and we use HA, which is a high concentration, whereas when it comes to latanoprost, it's such a 1,000 times lower concentration we use it. The question obviously raises that why so? So this is completely depends upon the physicochemical property of a drug as well as the functions of the cornea. We must make them understand that the eye is completely enclosed structure with the hydrostatic pressure is very high and much more sophisticated transporter mechanisms which are present in the cornea as well as the retina, so that the drugs, whatever you use systemically or topically, just they can't go in, and that is how it is protecting itself. So when you're just trying to come to pharmacology, it's not just only the sympathetic and parasympathetic system as far as iris and ciliary muscle is concerned. There are so many other places like corneal epithelium, corneal endothelium, trabecular meshwork, retina choroid. They're all having this kind of autonomic receptors. And really speaking, that this means no much of work has been done in this area to understand about their involvement in case of any ocular pathologies. Really, we don't know, but they are not limited only to this. This opens the idea about working about, to understand more about the side effects of many drugs. So when you just get into the pharmacology of the cornea, corneal pharmacologically, when I look into it, corneal epithelium is having very hydrophobic type, and the corneal stroma is more hydrophilic. Therefore, both hydrophobic drugs, they just can't pass through us easily. Therefore, they need to look for, they have some sort of an equilibrium and sort of a lipid solubility which is capable of going inside. So like even the drug delivery systems cannot cross, they just stay on the only outer epithelium, 1 or 2 layers of the outer epithelium, they can't just cross. So the cornea, always the drug takes through the cornea, transcellular route through which the drug goes inside the cornea because of the zona occludens, then it reaches the consumer. Some set of drugs, corneal epithelium is having a lot of enzymes like esterases and amidases, which are capable of cleaving these prodrugs like dipivefrin or latanoprost. They get converted into respective pharmacologically active agents so that they can go inside and they do action. And when we go for a single dose administration or multiple dose administration, it is always important that when we see the examples of voriconazole, when we instilled as a single drop every 2 hours or we instilled every 1 hour, there is a drastic difference. So sometimes we need to look for it for a good concentration, but at the same time that we should not overshoot also. So when it comes to dry eye medications, again, the understanding of postgraduates are very, very poor because we never deal this kind of thing at all. So we know now about that not only the dry eye where we look for it for a mucin, soluble mucin or insoluble mucin, and trying to anchorage on the microvilli on the corneal epithelium. There is also a monolayer of lipids, and the lipids are, there are 3 layers of lipid which is present, which is in the water-air interface in the tear layer, and that is preventing evaporation, where HPMC, MC, PVP, hyaluronic acid, they're all behaving as a mucoadhesives, whereas the glycerin, propylene glycol, PEG, Thralose, they are behaving as a moisturizers. Therefore, choosing an eye drop for this kind of conditions of dry eye is again another big science, which cannot be comprehended in this meeting. But this is very important to understand that. When it comes to ocular pharmacology, it's another big chapter, but how the drug goes, when you just instill eye or just trying to give by IV, how it is getting disposed from the eye. It is again through the mechanism of just getting into the, either through conjunctiva sclera, then it reaches inside, or it gets into iris, that gets absorbed. Or when you are going for intravitreal administration, either it follows the anterior elimination pathway or posterior elimination pathway through retina, and it is after the tissue distribution. Therefore, the drug elimination pathways are the most important thing when you come to antibiotics. For example, if you give gentamicin, it's excreted through the anterior pathway. When you give any other antibiotic that or any other drug, just quickly just transported to retina immediately out of it. And side effect of topical drugs are another most important thing. We use sometimes the 1% atropine eye drop. One drop would be equivalent to 0.5 milligram. This is a Goodman-Gilman talks about. At 0.5 milligram, when it gets systemically absorbed, what type of cardiac effect you will be getting on. Therefore, autonomic drugs are very important which can cause severe atropinization. That not only this drugs, any other drug through nasolacrimal drainage. So this has to be informed about it. Then we which is already discussed a little bit about it, about when the drug is administered through intravitreal route or systemic route, they always try to get inside the eye, but it depends upon the nature of the drug. They won't allow, they will not be allowed inside the eye, or they are just pumped outside. So therefore, reaching the concentration which is critical to reach the MIC90 of a microbe is also very important. That is completely dependent upon the compound. But at the same time, that when you try to administer the drug by intravenous route, when it reaches there and it is trying to equilibrate with all body tissues, again, I must tell you that the barrier functions of the eye won't allow them to get inside. So when you just look into this gamma camera image, when the animal has been injected with radiolabeled ofloxacin, you see that it's getting excreted, and you can see clearly in the bladder. When it has been blocked, the transporters are blocked in the eye, you will not see much about it. So this kind of things, when you inject the same thing by intravitreally, for example, retinoblastoma, when you try to give a chemotherapeutic intravitreally, they just pump it up and it is excreted very fast. I just take another 1 minute to complete it off. So there's a positively charged. That is why we use something like ceftazidime and vancomycin. They are positively charged compounds to intravitreally for endophthalmitis. We don't use any other agent. There is a scientific basis behind it. So ophthalmic formulations are many and worked in ophthalmology. We have more than 25 to 40 extemporaneously drugs which are available, which we make it for patient use. And most of our postgraduates reach outside. They always call up that. So can you please give me the formula so that we can just try to make this for our clinic. So there are many of them. We have a small list of things, that how much amount of diluent do we use to reach the final concentration, how long we'll be able to use. All these things are listed here, and it is also been listed in this book, which is Ocular Pharmacology of Ocular Therapeutics. One will be able to see. And in case if you need any further help, please just do write to us, that we'll be able to help you. Thank you very much for allowing me to give this presentation. Thanks a lot.
Fantastic, Velpandian sir. Nothing more we could really thought of. Really a wonderful talk. Thank you so much for coming over here. Can I ask our expert panelist? We have Dr. Savitri Sharma and Dr. Sushmita Kaushik, madam. Kaushik, madam, do you have any questions or any discussions to make on?
Yeah, Dr. Velpandian, something that we, especially who deal with very tiny children, I'm sure our ROP colleagues and the newborn glaucoma people are the most. So we've actually come across a couple of babies who've had Cushing syndrome because of exogenous steroid. So how much is enough, and should we have a smaller drop size? If it's a 1.5 kilo or 2 kilo baby, we are using the same drop as we would use in an 80 kg man. So something about steroids, which is what concerns us a lot. And how do we know which one, which skin cream, which inhaler is going to, because we've seen children who go blind because of that, because people don't know. If you can just touch upon that.
The same thing came up from our colleagues here also.
Yeah.
The thing is that when you try to reduce the drop size is completely a form of physiochemical parameter. When you try to optimize that, that cannot be done by any of the available formulations. It has to be specially formulated for the kids. When we were trying to do that, the problem is that immediately the commercial angle comes into picture. No company wanted to take it further for making that kind of thing. But definitely that, if all we requested is that, we were trying to encourage some people to have some more in-house pharmacy to be developed, and that is capable of handling this. And this is what most important thing for any of the good ophthalmology institute should have their own pharmacy department to handle all this kind of thing. Then even they can be able to do any, we make Avastin, we made, the remarkable contribution of Avastin, which came up in 2006. I started giving in Nampule, and that is unbeaten even today. So, such a type of thing for the country like ours of great help, ma'am. So for this, I would strongly recommend that institution supposed to come up. We will be very happy to train the pharmacists to handle it.
Okay, right. Thank you.
Sure, ma'am.
Savitri, madam.
Yes, very nice, fantastic talks. I was expecting Velpandian to mention about natasol,
Yes,
which has made a really big difference. And
Yes,
when
ma'am.
is it likely to come to market?
Ma'am, I think there's one company is picking up now. That my colleague, I think she's going to talk about that in the conference. Therefore, I did not touch about it.
Okay.
It's one of the innovation. Exactly,
that
ma'am.
will be a good relief for the fungal keratitis treatment.
Exactly, ma'am. I think that company is picking up now, so we are expecting this to come to market soon.
Yeah. All right, Ved. Thank you so much for a nice talk. The other one was about Dr. Subhashini's talk. I just thought that because we are residents, we also teach them to do gram stain and at least KOH preparation with the corneal ulcers. So I would actually include that in one of the initial things that any ophthalmologist treating corneal infections is good for them to learn that.
One comment about about Dr. Subhashini's talk, I would just like to add that I think we should also train our people to first look at them clinically and then tailor investigations as to what you see. You see, so what happens now in the retina clinic, somebody goes and the first thing they write is OCT picture or fundus picture, and then see the fundus picture, then make a diagnosis, and then try to correlate what they're seeing and make a retrospective diagnosis. And this to me is absolute anathema. You see angle closure, don't ask for an ASOCT, do your gonioscopy. If you think the lens vault is too high, ask for an ASOCT for lens vault. But I think if we gray-haired people emphasize this every time, keep patient dekho, then send, I think that's very important. Just a little bit of that.
I think it's very, very important. Yeah.
Very, very rightly said, Sushmita madam. I think in the younger generation, picking up more with the innovations and the technology, and like in case of retinal, this thing, it's very difficult to indent and looking for the peripheral lattice degenerations or do that. Rather get an optos where you see the peripheral lattices. In fact, when I was studying in Toronto, we used to get a lot of patients from the optometrists who used to have these high fancy gadgets. And my mentor used to tell me, don't try to miss any peripheral retinal findings because it is documented by the optos. So better be sure that you indent and do this. So that's the advancement of the technology, madam. I think we have to accept it. And definitely now AI is probably going to throw us out and it's going to do most of the job. But
no. I don't think it's going to do that at all.
Yeah. Good. Professor Velpandian, last question before we move on to Jyotirmay Biswas sir.
Yes.
So what is your role in Serigolan? I see in case of NAION, AION, whatever it is, many of the doctors are, is it like an antioxidant what we are using, or is it really doing a neuroprotective action?
I'm not convinced as of now with Serigolan. It's just, it's like, Bremonid, and immediately people said that, it's having retinoprotective activity. But, if you want anything to go inside, it has to reach inside. I mean, that kind of studies are so far not done to say that whether it is capable of. It's all going with some sort of assumption and things like that. So I'm not in the favor of it. It's just going as 1+1.